Hi, welcome back to the Pedortic program. In another year of firsts, this is our first virtual conference, hopefully our last, but we'll see what's in store for us. The next speaker, Dr. Katia Langton, is the first chiropractor we've had come to the conference, and she's also a certified pedorthist. She has a private practice, Ocean Walk Pedortics, in British Columbia in Canada. And, she focuses on the general things that we see on a daily basis, people with postural problems, osteoarthritis, and specifically, she has a passion for diabetic foot care, which is the reason that I invited her onto this program. I first met Dr. Langton at the AOPA conference in San Diego way back in 2019. That seems so long ago. At that conference, she showcased and spoke about the tremendous work that's been done by the International Diabetes Federation. That's a huge organization that looks at and considers diabetic foot care from the point of view of clinical practitioners like ourselves, but also from the point of view of the patients. So it's a very large organization. They have done tremendous work looking at the issues behind many aspects of the problems of diabetes, but they have also a focus on diabetic foot care, realizing that that's often the first symptom and a primary debilitating factor with diabetic patients. Dr. Langton is on their foot care task force, and they prepare material that's easily digestible by anyone in the allied healthcare professions. So it's not just for specialists in foot care, podiatrists and pedorthists like ourselves, but also for pharmacists or nurse practitioners and other people. The work they've done is great. She'll speak about some of it, but I encourage all of you to look at what's available from the International Diabetes Federation. Dr. Langton, first time again at the program. Great to have you here, and over to you. Thank you very much.
Thank you very much, Seamus, and thank you for inviting me. I'm thrilled to be doing this talk. I love talking about the diabetic foot and preventing diabetic foot ulcers and amputations through education of all our healthcare practitioners. The pathways are really not well understood on how to prevent diabetic foot complications. It's not well managed, and it leads to devastating consequences of loss of limbs and loss of lives. And 85% of the amputations are preventable. So I just love doing this talk, and I'm very happy to be invited. So what's my story? Well, I started out as a chiropractor, and I worked primarily with patients with pain. And then I retrained as a pedorthist in the US. And then I retrained as further as a Canadian pedorthist. And then I did some training down in Louisiana at the Leprosy Hospital. And then when I came back, I got appointed to the Canadian Diabetes Association to do some lecturing for them on how to prevent diabetic foot complications. And then I also, in April 2016, got appointed onto the IDF, the International Diabetes Federation, onto the Diabetic Foot Stream Committee, where we were tasked with creating guidelines to care and prevent problems with the diabetic foot. And those guidelines actually got published in June of 2017. So I thought it was going to be a really easy transition going from treating pain in chiropractic patients to treating painlessness. But what I didn't realize, it was going to be a very difficult transition. And treating painlessness is much more difficult than treating painful conditions. When we get started, I wanted to recognize my instructor, Bill Meanwell. He was my first podorthist instructor. He's no longer with us, and we miss you, Bill. He was inspiring. He was a great teacher and mentor, and he taught me multiple things. The biggest thing he taught me was that about the diabetic foot. But he said to me, he said, you know, we've got as many patients with diabetes here in the US as you have all of population in Canada. And so I was amazed. And also, I didn't even really understand what the diabetic foot had to do with diabetes. Like, I just didn't understand the connection. He was the first one that taught me how the elevated sugars lead to the destruction of the diabetic foot. He also taught me that within the podorthic profession, there's so many different jobs. You can work in a shoe store, or your own lab, or you can be employed, or you can do education. So that was really interesting as I was just becoming a podorthist. And the other thing he taught me is find the work that you can't not do. So in terms of finding inspiring work that you can't not do, this is it for me. So I hope that you learn a lot today, and we'll get right to it here. So I got involved in this because I really understood that in each profession, there's a few key people that understand the whole progression from freshly diagnosed diabetic to the very end, which is death. But there's only a few that really understand how to stop the progression. So there isn't one profession, whether you're a chiropodist, podorthist, prosthetist, orthotist, medical doctor, nurse practitioner, endocrinologist, orthopedic surgeon, podiatrist. There isn't really one profession that truly understands that. So as the podorthic profession, we're really poised in a very good position to truly understand and truly own this so that we can help these patients, educate the patients and educate the other healthcare practitioners, and really own how that patient is prevented from going down this deleterious pathway. Because the pathway from freshly diagnosed diabetic to insensate with neuropathy to limited joint mobility to fungally infected with onychomycosis to limited range of motion and to a Charcot foot and ulcers and amputations and then to death is really not well understood. So that's what we want to understand, because if we understand the progression, we can understand how to prevent going down that pathway. So what we're going to talk about today is the global burden of diabetes and its complications due to gaps in care. We're going to talk about differentiating patients into 3 categories in clinic: the diabetic foot disease, the pathway to destruction, how onychomycosis or fungal infection in the nails elevates that risk, and how to fill the gap and have the pathway to prevention of the diabetic foot. And this is Dr. Jean-Claude Mabagna. He is the president of the IDF from 2009 to 2012. And I met him at the World Congress Conference in 2015. And I found him and I asked him to take a picture with me. And I told him I was very inspired by his speech. And he asked me what speech. And I said, the one that you made in 2011, where you said the epidemic is out of control. We are losing ground in the fight against diabetes. No country is immune and no country is able to repel this common enemy. So that was a very inspiring speech. And I got this picture with him and I was thrilled because he was my mentor from afar. And he was right to make that speech because we are losing ground. Where we are right now is we're on the burning platform. So the burning platform comes from an explosion that was in 1988 in the North Atlantic Sea. And what happened is there was a number of workers that were injured, that were burned, that died. It was a horrible incident. What happened? One of the workers, Andy, he woke up and he he was burned, and he had to make a decision what to do. He's on the burning platform, and he's for sure going to die. So he has certain death. His choice was to fall 15 stories into the cold Atlantic Sea, and he would have probable death. He might die during the fall, and if he didn't get rescued within 20 minutes, he was for sure going to freeze to death. He actually jumped, he was saved, and they interviewed him on the news, and they said, "Andy, why did you jump?" And he said, "Well, jump or fry." So good answer. So what happened is this has become synonymous with organizational change that must happen. So with the diabetic foot, we are on the burning platform. We can't stay with the way that we're treating it. With the complications and the staggering costs and increasing numbers, we've got to make that jump off the burning platform into the sea, just like Andy did. And why do we need to do that? Because we have poor understanding of the progression of the diabetic foot. If we don't understand how these patients go into the pathway of destruction, we won't understand how to prevent them. And we can't expect the patients to understand it if we as the healthcare practitioners do not understand it. We've got a poor adherence to international and national guidelines on how to protect the diabetic foot. We've got staggering costs that are increasing at an alarming rate, and we've got diabetes cases globally are increasing at an alarming rate. And that is why we're on the burning platform. At this point, we need to reconceptualize the diabetic foot as a disease entity in its own right. So we treat it individually, not just as a part of a patient with diabetes, but to be looking at it each time they come into clinic. The diabetes is a global health emergency. You can see over the last few decades how it's increasing at an alarming rate. You can see that even over the last, over a 5-year spread, how it almost doubled in costs. These costs of billions of dollars in each country, it's unsustainable. We need to get a handle on this. And why are we so behind in treating the diabetic foot? Well, there's gaps in care, gaps in treating diabetic foot disease. We've got failure to treat preventatively in the window of presentation. And if we don't even know what the window of presentation is, it's hard to treat here. The window of presentation is actually when the patient presents with neuropathy, but before an ulcer or amputation happens. We want to treat them aggressively, offload them, protect them so they never get into that risk category 3 of an ulcer, amputation, Charcot foot. Failure to recognize and the need to escalate and refer appropriately. As soon as they have neuropathy, they need to be referred on to a person like us, a podorthist, to offload them, to protect them, to put them in diabetic shoes, diabetic devices. If they have wounds, they need to be put into a wound shoe quickly. If they have vascular problems, they need to go get a vascular assessment or see a wound clinic. We need to not hold on to these patients, but refer them appropriately. What other gaps do we have in treating the diabetic foot? We have lots. The lack of understanding with the patient, lack of understanding with healthcare providers, insufficient training, suboptimal assessments, the failure to carry out regular diabetic foot screenings due to time, knowledge, lack of reimbursement, lack of knowledge that the onychomycosis, the fungal infection, elevates the risk of foot complications and is not just a cosmetic problem. We've got limited access to multidisciplinary teams for ulcer care and poor access for preventative assessments and preventative treatments, and lack of adherence to the national and best practice guidelines for treating the diabetic foot. We've got so many gaps in care. What are the consequences of these gaps? 15 to 25% of the diabetic patients will develop a diabetic foot ulcer in their lifetime. Up to 55% of them will be dead within 5 years. So it's not well understood that the diabetic ulcers have a 5-year mortality rate for 55%. And 1 in 5 foot ulcers will lead to a lower extremity amputation. There's more gaps. 50% of those with the diabetes-related amputation will be dead within the first 3 years, and 80% within 5 years. So there's an 80% 5-year mortality rate. And this is only second to lung cancer, which is 86%. So everybody knows that lung cancer is going to get you. And they also know that colon and breast and prostate cancer is going to get you. But what they don't understand is that diabetic related amputations are well above colon, breast, and prostate cancer. So if we understood that better, we'd get a quicker handle on this. Because what we're seeing is all these unnecessary ulcers and amputations. So the patients don't just show up in clinic one day needing an amputation. There's checks and balances along the way. There's markers and hints of problems along the way. So the healthcare practitioners need to understand and need to treat this earlier. We not just wait until it's like acute crisis care and they need an amputation. We could have solved these things a lot earlier if they were picked up and understood and treated preventatively. So now we're going to talk about differentiating patients into 3 categories in clinic. Now, why is this so important? Because actually nobody else is doing it. So don't think that it is being done by anybody else, because as the podorthist, this is what we need to do, because it's not like their medical doctor and nurse practitioner, they're not going to do all this stuff. We have to do it and report back to them. So the patient's confused. They don't know which one is mechanical foot pain, which one's the back referring down, which also causes neuropathy. And then the diabetic peripheral neuropathy causes problems from the feet up. So remember that neuropathy is just nerves dying. So we need to differentiate if, number 2, lumbar spinal stenosis is just degeneration in the spine that is killing off the nerves, but from the back down. And we can figure this out by our line of questioning and history taking. The third one, the diabetic peripheral neuropathy, that always progresses distal to proximal. So it's going to kill off the smallest nerves first in the toes and then work proximal. So again, we can figure this out by our line of questioning with the patient, so we know what we need to do for them or how to refer them. So let's go through this. The mechanical foot pain is going to cause pain with weight bearing and mobility. It's really important that we figure this out and also fix these problems, because the goal is to keep them active, walking, and mobile so that they can manage their blood sugars. They can manage their A1Cs, and the magic number is 7, and keep them 7 or below so that the sugars don't go too high and cause the neuropathy. So we get them to, where are you getting pain in your feet? Point with one finger, rate it 1 out of 10, 10 being the worst. Is it getting better or worse over time? So this is what we can figure out from the history taking. And, there's all sorts of painful foot conditions, plantar fasciitis, posterior tibial tendon dysfunction, Morton's neuroma. All of these painful things are going to stop the patient from walking. If they can't walk, if walking is not rewarding, they're in, agony after walking, they're not going to do it. And with diabetes, you have to walk 30 minutes a day. That's like the minimum, and walking has to be your friend. So we have to correct these mechanical foot problems, which are actually a lot easier to correct than the neuropathy problems. Now, the other one is lumbar spinal stenosis. What that is degeneration in the spine that is pressing into the spinal cord. So what happens is, with an aging population where we see a very high percentage, sort of 70% of our over 70 population is going to have some sort of lumbar spinal stenosis. So the degeneration in the bony spine will press into the anterior spinal cord. The ligaments will buckle or the discs will fold in there. What happens is these patients get neuropathy, but they get it from the back down. So it's when they're upright and walking, because what happens is it impedes the venous return to the spinal nerves in the spinal canal due to the narrowing. Stenosis just means narrowing. So it's impeding it's causing a venous blockage that causes an obstruction of the cerebrospinal fluid that bathes the nerves. Then that blocks the arterial supply to the nerves, which nourishes the nerve, and it starts to kill off the nerves. It happens when they're up shopping cart. This is called dubbed shopping cart syndrome, because they get relief when they bend forward, because you're opening up the spinal canal, and it is it's increasing the blood flow. So we want to make sure that we rule this out. Refer these patients for appropriate treatment if it's coming from the back down. This is Dr. Ed Jude. He was my partner in the IDF on the diabetic foot stream committee, and he is an endocrinologist in the UK, and we did this research project together of how stenosis can mimic diabetic neuropathy. We presented it at the Portugal conference in September of 2017. At the Diabetic Foot Study Group. So this is really important to separate out. And then lastly, it's the diabetic peripheral neuropathy. So this is the one that we're trying to figure out from our line of questioning if this is what is going on. Because remember, the neuropathy is coming. So neuropathy just means nerves dying from sugars in the bloodstream. So what happens, diabetes is a disease of too much sugar in the bloodstream. So the insulin is the hormone that turns the key or opens the door to take the glucose out of the bloodstream and put it in the cells and store it, because we don't want too much sugar in the bloodstream. So what happens with type 1 diabetes, which is 5% of it, is there's the beta islet cells of the pancreas does not produce enough insulin to turn the key to open the door. So there's not enough insulin. With type 2, which is 95%, this is the population that is increasingly sedentary, and due to poor diet, the insulin becomes weak and it's resistant. There's too much sugar and it becomes too weak to turn the key to open the door to uptake it. And with the obese patients, there's fat around the cell, and that further inhibits the insulin from being able to uptake it out of the cells. So we get too much blood sugar. Now, glucose is a highly reactive compound, and normally it needs insulin to get it out of the bloodstream, but glucose can freely flow into the neuron cells, the nerve cells, and into the retina and the kidney. And this is where it wreaks havoc. So when it gets into the bloodstream, into the blood vessels, it damages the endothelial small lining of the blood vessel. And it goes into the feet first. They're the smallest. It's highly predictive of retinopathy in the eye because it's the same size blood vessels. It starts to kill off the blood vessels in the feet. Now, there's an interplay between blood and nerves. You can't have proper nerve health without blood flow to nourish, and you can't have proper blood flow without the nerves innervating the blood vessels. So there's an interplay between both. When one dies off, the other. So we start to kill off the blood vessels in the feet, we start to kill off the nerves in the feet. So then as soon as we get neuropathy, we're going to be able to assess this by putting up the patients, because neuropathy is the number one thing that tells us where they are in the risk category chart. So this is from the IDF. I encourage you all to go on to the IDF website and print this off. Risk category 0, 1, 2, 3. This is the basis of treating and protecting the diabetic foot. The 0 risk category is we don't find any neuropathy. They're in good shape. They just need to see us for a checkup in 1 year's time, and they need to manage their blood sugars and keep their A1Cs 7 and below. Risk category 1, we find some neuropathy. We're going to test 10 areas on the bottom of the foot with a monofilament. We'll get into that in a bit. It's fishing wire, and if they can't feel even one area, they're into risk category 1. And then they get pushed into risk category 2 if they have loss of protective sensation, which is feeling in the feet, and either poor circulation, painful foot conditions, structural deformities, or onychomycosis. Fungus will push them into risk category 1 to 2. 3 is the risk category of ulcers, amputations, or the Charcot foot, or a history of ulcer amputations or the Charcot foot. So we want to stay well far away of risk category 3. We want to see them earlier, and the window of presentation is treating them aggressively in that risk category 1 and 2. So let's go through that. The pathway of the diabetic foot disease, the pathway to destruction, which all starts with neuropathy. We know that 70% of the diabetic patients are eventually going to lose some feeling, or we call it protective sensation in the feet. When you're doing your history taking with these patients, you're asking them at night and at rest, are you getting any numbing and tingling at night and at rest? If so, is it constant? Is it just at night? It'll eventually become, with unmanaged blood sugars, it's eventually going to become constant, but it starts as intermittent occasionally at night, and then it progresses. So it can be numbing and tingling. It can be the sensation of bugs crawling. It can be painful, like sharp shooting pains up the legs. And they're going to eventually they're going to have a whole bunch of complaints about loss of balance. But just to stay in this realm, in the questioning, we want to separate this out from the mechanical foot pain. So when they start to get this is when our alarm bells should be going off. When we figure out they have neuropathy, we should be getting ding, ding, ding. This is when we treat them aggressively. This is when we assess them and they're in risk category 1. This is where we want to protectively start to offload and protect that diabetic foot. So what happens is that the damage to the nerves starts off by killing off the large myelinated fibers, and that is it's the vibration position sense, and it's the small motor nerves. It will then progress onto the small myelinated and then onto the small unmyelinated, which is pain and temperature. So when we see this in the early stages, we're going to see that it denervates the lumbrical muscles in the toes, which allow the toes to sit flat and extend. Now, what happens is then the opposing muscles take over, and it flexes the toe at the IP joint and extends the toe at the metatarsophalangeal joint. So we get this hammering of the toes, and then in the later stages, we see that we start to get the intrinsic minus foot. So we see the hammering of the toes, the downward pressure on the metatarsal heads. And then we also see what happens is there's a fat pad underneath the metatarsal heads. And when we start to get the distortion of the foot, now with motor, now this is motor and sensory neuropathy together, we start to see the atrophy of the fat pad underneath the metatarsal head, and it also gets pulled distally. So it leaves it open and vulnerable, and there's no protection here. You also lose the fat pad in the calcaneus. It also starts to atrophy along with the lumbrical and interosseous muscles. And we see an increased arch height. Now we see this due to the denervation of the muscles, and the atrophy, but we also see this because we start to get glycosylation, which is the deposition of the AGEs, the advanced glycated end products, which is the glucose, and it's depositing and creating fibrous tendons in the Achilles tendon. So it's starting these end products are starting to deposit into the Achilles tendon, and that will shorten it. You get the cross-linking, and the foot becomes less supple. It becomes less viscoelastic, okay? So it becomes stiffer and more rigid. So the Achilles starts to glycosylate, and it starts to shorten. And that increases downward pressure on the forefoot, which is most common area to get wound. It also, so it causes like an Aquinas syndrome. So now the foot can't do its two main functions, which is to adapt to terrain and absorb shock. Now, sometimes it looks like this, but when the foot is weight bearing, it also collapses. It has to do with what's happening with the mechanics of the foot. So, but this distortion is causing a loss of surface area, which increases peak pressure. So we're going to go through that, because peak pressure is anywhere where there's too much body weight. There's peak pressures coming down on certain areas of the foot that are bearing more weight due to the changes with the motor neuropathy. And peak pressures cause calluses. So calluses are the hardened nodules. It's the body's way to protect itself. So the problem with these calluses is they can, they're first of all, they're hard. On the picture on the left is a rock taped to the bottom of the foot, and on the right is the callus. There's actually no difference between these two scenarios. So the callus is just like a rock, and it's putting upward pressure into the soft tissues, and it will eventually open up as a wound. So as soon as we see that callus, I work with the foot care nurse. We don't even let that patient leave. That callus has to come off, because calluses will open up to ulcers. Now you have a problem, because you have an open pathway of entry for bacteria to cause a deep-seated infection here. So we end up getting this perfect storm, the limited joint mobility, which is the glycosylation of the glucose with the cartilage and connective tissue. It's causing a very rigid foot that's unable to absorb shock and adapt to terrain. And when you pair that with the high peak plantar pressures from the distortion of the foot from the intrinsic minus foot, you end up getting this repetitive pressure while walking. The studies show that these diabetic patients that can't feel their feet have no need to alter their stride. So they don't alter their stride. They keep walking with, all their weight on their heel or all their weight on their forefoot, and they're just traumatizing these tissues. And then we start to get plantar ulceration in these neuropathic individuals. So it is the perfect storm, because now we've got these high sugars, which has actually, it decreases the body's ability to respond. The white blood cells are unable to respond properly. They are immunocompromised. And it's very difficult to heal this wound. Also, with the wound and the high sugars, bacteria love sugar. It puts out the welcoming mat. So we see these ulcers, and now these just aren't little red sores. These are big, fat, red mortality markers that this patient has a very high likelihood that they could be dead within 5 years, 55% of them. So, and we have to get that wound closed quickly. So as podorthists, we're very well poised to get this patient in a wound shoe, offload them, and then get them in protective diabetic orthotics and footwear. The rule of thumb is if this wound is not 50% closed in 4 weeks, it's unlikely it's going to close by week 12. And the longer that this is open, the higher risk of an infection that is going to overwhelm the host's ability to deal with this infection, which can lead down a very deleterious pathway. And that's not the worst, is a wound. What we're really truly worried about is Charcot osteoarthropathy. This is the ultimate consequence. This is the chronic, progressive, total destruction of a weight-bearing joint. So what this is a neuropathic foot that's traumatized with walking. So this patient cannot feel their foot. They walk, and there is increased blood flow to the feet. There's increased chemical mediators and inflammatory markers. And what that does is it starts to soften the bones. And it also increases osteoclastic activity, which is bone resorption. So it becomes osteopenic, like thinning, and it also resorbs the bone. And then the bones can, if the patient keeps walking, their body weight keeps coming on this, it will eventually cause fragmentation and fracture and collapse. So what we want to do is this is end stage on the left, right? And on both, they're actually stage 3. What we want to do is pick this up early. And this doesn't just have to be in your diabetic patients, because it's from neuropathy. It's not necessarily from diabetes, because I had a patient that came with stenosis causing neuropathy, and 3 doctors in a row had missed it because she wasn't diabetic, but she did have stenosis. So with neuropathy, you can end up with the Charcot collapse, and it is in 9% of our neuropathic patients. So you're all are going to see this in your clinics. So what do we do? The patient presents. If they're in stage 0, the foot is just hot. So they come in, it's hot, swollen, and red. That is our marker. Now, what we will also see is the patient is neuropathic, so they can't feel pain. But the big clue is because there's inflammation and it's deep in the bony level, they have pain. They're complaining of pain, yet they can't even feel pain. So that's a big fat marker and a big red flag. And the other thing is temperature is the best remaining marker of traumatized tissue starting to break down. So we take our handheld thermometer, and we take from the foot in question to the good foot, we take the temperature. If the foot in question, it has 2 degrees higher of Celsius or 4 degrees of Fahrenheit, a more elevated temperature, we've got either a Charcot foot or an infected foot on our hands. If we don't have an open portal of entry, then it's probably Charcot. So until we know, we have to treat it like a Charcot. So we want to put this patient in immediate offloading. So whether that is an air cast, bed rest, a wheelchair, they can't walk on it. We need an X-ray. The X-ray will show us if the second metatarsal head is in line with the medial cuneiform. That's the keystone. We can see that on X-ray. We can see if it's slipping in stage 1, which is where it starts to go through the fragmentation stage. And you'll start to see the changes on X-ray. And then we can also get nuclear imaging, which is a bone scan. What we want to do is protect this foot, because the foot is like a loose bag of bones, like sponges. So the bones are soft, but what's happening is the Achilles, the extension muscles, and the peroneus are still strong. And those muscles bowstring and pull up as the foot drops down. So we get this rocker bottom foot in the stage 3. If we can catch this early in stage 0 or stage 1, we can lock up the foot, non-weight bearing, in a cast until they go into stage into the consolidation stage, where the bones start to solidify again. Then they can come out and go into diabetic orthotics and shoes so that they're protected, as there's a high reoccurrence rate. And the goal of treating this Charcot foot is that the foot at the end still looks like a foot, and it's plantargrade to the ground so that they can still walk. So we want to catch that early. Now let's talk about fungus. That's my favorite. So onychomycosis. It's not well understood how fungus elevates you from risk category 1 to risk category 2. The way that it does is it's putting the patient at risk because the fungus it's an opportunistic parasitic infection that feeds on dead tissues. So it's feeding on the nail. It eats the keratin in the nail. The nail over responds by laying down more keratin and it thickens. The whole nail thickens. As it thickens, it pulls away from the nail bed and it creates portals of entry that allow now bacteria to get into the bloodstream. So remember, this nail has both bacteria and fungus in the nail, and they can both get in that portal of entry and cause a very synergistic infection that can work in the bloodstream to overwhelm the host's ability to deal with the infection. That can lead down a very bad pathway. Whereas we can treat this early. So the fungus, we want to treat it here. We can treat it in the early stages with more topical medications, because we wait too long and it looks like this, right? It's really advanced fungus. So there's oral medications and there's topicals. The orals are cheap, but they're not cheerful. They're actually quite toxic, and you need liver testing in order to do it first, or to go on them, and most likely they're on too many medications that they're not going to pass the liver testing to go on it or even be allowed to start. So what do? We put them on the topicals, but if we send them to a foot care nurse, which will thin the nails, it'll make the nail more porous so that the little gold in the bottles will go further to kill off the fungus infection. And don't forget that the shoes are colonized, right? So every day they're putting their shoes on that are not treated, they're reinfecting themselves. So the shoes need to go in the freezer every 6 months for 48 hours. And also the fungus powder needs to be put in the shoe every day, because this is an infection the body can't recognize, can't treat, and it literally is putting the welcome mat out. If we don't treat it here, it's going to cross-infect into the skin. It starts to eat the skin, and it starts to create fissures, which are open portals as well. It'll cross-infect into the fingernails and also into whoever shares the shower with the patient. And also, because of the thickening, it can just cause wounds that are, again, like not even just open portals, just big wounds that we have trouble closing. There's an increased 2 to 4 times incidence of gangrene and foot ulcers in our diabetic patients that have onychomycosis. So it's really important to get this under control. So lots of information here. We have to learn this first before we can truly teach the patients all this. So let's talk about filling the gap and the pathway to prevention. So here is the IDF guidelines. We got these published in June of 2017. And I urge you all to go onto the IDF website and print these off and take a look at them. This is everything in this talk is what is in the guidelines and more. So they're quite good. They're very well written, if I may say so myself. And what we do is we go through the comprehensive foot exam. So looking at, first of all, their level of neuropathy, motor neuropathy, structural foot deformities, painful foot conditions, vascular blood flow, integrity of the nail and the skin, and also the footwear that they're actually wearing. So there's a little pocket chart here. So it's made up of the 6 sections here: the introduction, neuropathy, arterial disease, infection, ulceration, and our most feared consequence, the Charcot foot. And then there's a little pocket chart for the healthcare practitioners. So there's lots of good resources on there. Now, the goal of these guidelines are 2 things. One, we want healthcare practitioners to intervene early. We want you to intervene in risk category 1 and 2, which is a moderate to high risk, and well before 3, which was urgent, which is those ulcers, amputations, and Charcot foot or history. So if we can aggressively intervene in risk category 1 and 2, they will never progress to risk category 3, most likely. That's where we want to live, because once we have a wound opened up, they're very difficult to close. And the second goal of the guideline is mobility. Keep them on the ground walking so that the patients can manage their blood sugars and fight their disease. If they can't walk, if they become sedentary because of foot pain or because they've already got too much neuropathy, that when they walk, they don't have the balance and they feel like they're going to fall over, they're not going to walk. And if they've got stenosis, degeneration in their back, and it impedes the blood flow, like a tourniquet, and they can only walk for 15 minutes and they get excruciating lower extremity problems and pain and numbing and tingling and hip pain, again, they're unable to walk. If it goes too far, they can barely cross the parking lot. So it's really important to keep them mobile so they can manage their A1Cs, so their blood sugars are 7 and below. That is the goals of the guidelines. Now, the IDF has asked us to focus on, we want to prevent new cases. And if we focus on activity as well as the diet changes, we can prevent millions and millions of cases in the next few years. And also the patients that are already diagnosed with diabetes, then we want to stop their progression up the risk categories. So how do we do that? We're going to talk about these comprehensive foot care programs that can prevent 85% of these amputations. So we'll go through this. Again, the risk category chart. I wanted you to see it earlier. Now we're touching on it again. 0 is no neuropathy. Come back in 12 months for an assessment, manage your blood sugars. 1 and 2, they get to see you more frequently. And, within 6 to 12 months, and they get treated and preventatively loaded, and you can deal with any of the other problems. Fungus, you can refer them for treatments for fungus, vascular, and you can treat their painful foot conditions to keep them walking. And then the last risk category, which we already have too many of, we're trying to stay away from, but if you see the patients in that's a wound shoe to offload them. So here's the monofilament. This is the mainstay of the risk category chart. It's all based on what they can feel. So we use the 5.07 monofilament, which is 10 grams of pressure, which is the same pressure of walking. And we actually poke this, which is like fishing wire, into the bottom of the foot. And if they can feel the pressure, they say yes. They have their eyes closed. We do 10 areas. If they can't feel even just one, they're in risk category 1. And then if they can't feel, and that's considered light pressure. And if they can't feel that, we then have a deeper monofilament, which is the 6.1 monofilament, which is 75 grams of pressure. And we then do the same test. The Charcot patients have generally lost not only light, but deep pressure as well. By the time they come to see us, we're going to see, they've gone quite advanced with their neuropathy. From this, it tells us where they are in the risk category chart. And then we can see if there is 0, 1, 2, 3, we can communicate with other healthcare providers. If we need to refer out, we can write letters, send referrals, all that to get them the best care. So again, we want to treat in that window of presentation in risk category 1 and 2 aggressively. And now we all have a good idea what the window of presentation is. Management of the foot problems preventatively. So I work with a foot care nurse, and the foot care nurse has lots of time because they're with the patient every 6 weeks or 8 weeks for half an hour. They have lots of time to go through all this stuff, treat the infections, remove calluses, prevent ingrowns, moisturize the cracked heels so we don't have any fissures, which are open portals of entry, again, for bacteria and or fungus, remove corns. They're really going to prevent little problems from becoming big problems. You can see where the callus on the left, and then on the right, you can see where the callus was pushing upward into the soft tissues, and that could have created a wound if it wasn't removed. The foot care nurse can also do patient education because they're in there for half an hour. They are going to have lots of time to talk and go through all these things. It's really imperative that these patients with neuropathy that can't feel their feet check their feet before putting on their shoes. We had a patient that just put his gumboots on, went and pressure washed the driveway for 2 hours, mowed the lawn for 2 hours, came back, pulled off his boot, and he had a small box of Band-Aids in there. So he couldn't even tell. So he didn't check his shoes. He got a wound. The wound turned into a Charcot foot. And again, he went down a very bad pathway that all could have been prevented. Also, never walk barefoot, another key one. We had a patient that was walking around barefoot, even though we told him that his barefoot days are over. He walks around, he heard this clip, clip, clip. He turns around, there's a trail of blood behind him. So he didn't know there was a tack pushed into his foot. He couldn't feel it. So he got a wound. So you can see that education is so important. The patients have time to check their feet. They should be checking them 2-3 times a day. If they can't get to their feet, they can use a small mirror. And then offloading. This is what we do preventatively and in ulcer remission and aggressively to close ulcers. And so this is the leprosy hospital in Louisiana. And so this isn't medicine. This is mechanics. This is offloading. This is what we do best. So with pressure, peak pressure is what causes these ulcers and wounds. So pressure equals force over area. So force is the body weight coming down. That's a constant. Surface area, however, is where we can interface. So we saw with that intrinsic minus foot, there's very few areas that are actually on the ground. So if you say you take a 400-pound man, you've only got 4 square inches touching the ground. You get 200 divided by 4. It equals 50 pounds of pressure per square inch. That's lots of peak pressure coming down. If you interface and you add diabetic orthotics and footwear, you go up to 12 square inches. You actually get 200 divided by 12 now, and that reduces the peak pressure to 16.6. So big difference from 50. So we have really decreased the peak pressures coming down by increasing the surface area, which is what we do best with the diabetic orthotics and the diabetic footwear. Because when you have a round surface on a flat area, you're going to have a very small area of contact, which means high pressure. So you can see that the calcaneal tubercle and the metatarsal heads are bearing the majority of the weight, and even worse with the intrinsic minus foot. So here's how we interface with our custom contact device. We can get into that dead space and the whole foot becomes a weight-bearing surface. The arch is all filled in, so we definitely want it custom and contact, and that is how we're going to increase the surface area. With the orthotics, the diabetic orthotics, remember these are cushioning. These are cushioning because remember the foot becomes rigid, it's unable to adapt to terrain and absorb shocks. So we don't want a rigid, hard orthotic for these feet that are becoming glycosylated and equinus as the Achilles stiffens up. We want cushioning with plastizote and poron. We want to see pink plastizote because if a wound opens up, we want to be able to see blood. If a patient comes in with a hard black orthotic that's rigid, they didn't go to a practitioner that understands what to do for the diabetic foot. And footwear. So the diabetic footwear has extra width, it has extra depth, and it has it's seamless. So on the inside, it can't hurt the diabetic foot. And it also, you can modify it. So you can add in a rocker modification, which will decrease the weight bearing on the heel and the forefoot with forefoot rocker. So that is a whole other talk. But yeah, the shoes don't look like the clumpy shoes of yesteryear. They actually look quite fashionable now. So you can't even really tell. So offloading aggressively to close the wound. The longer the wound's open, the higher likelihood we're going to have an infection. So the first thing is if we want to deal with infection, if there is one. If the wound is offloaded and the wound is not infected, just leave it alone. It's not what you put on it, it's what you take off of it. So leave the wound alone. If the organism, the bacteria gets in, and because all wounds are colonized, but if the virulence and the number of the organism overwhelms the host's immune system and the host's capacity to deal with that wound, then you're going to get an infected wound. The symptoms are going to be hot, red, swollen, smelly, and there's going to be pus and discharge. Then we need some to treat the wound. We need to treat it with antibiotics. So that's the one thing that needs to be looked at. The other thing is blood flow. Check the patient's, pedal pulses, send them for a vascular assessment or an ankle brachial index if needed. We won't close a wound if we don't have blood flow. Bringing white blood cells, bringing all the mediators that are going to help close and heal this wound. So we have to have good blood flow. And then the third thing is pressure. Pressure is the number one thing that stops a wound from closing. So first of all, the dead tissue needs to be debrided. Debriding that dead tissue from a wound care nurse or a wound care doctor, that's going to take off 30% of the pressure. The rest of the pressure is walking. So remember, they can walk on this, right? The epithelial healing layer is so fragile that one footstep on that foot takes out a day's worth of healing. So if they're walking on this wound, this wound is never going to heal. So we need to offload them aggressively. So there's a number of things that will offload them, because the pressure and the weight that we take off is what is going to heal it. So there's a number of different wound shoes and casts and total contact casting and air casts, but sometimes we have to offload them into a wheelchair or bed rest. So the wheelchair is, we did have to use that when we had a patient with 2 Charcot foot. So we couldn't put her into air cast. She was just going to tip over. She didn't have the balance and stability. So we got to offload aggressively so that the wound can heal. And then we have to teach them they can't cheat. They can't even, if they go to the bathroom at night, they can't cheat or they're going to undo the healing. So we've learned a lot today. So the focus here is the diabetic foot. We want to reconceptualize the diabetic foot as a disease entity in its own right. No longer just looked at as an aside with the diabetic patient. We want to look at this individually with each diabetic patient and regularly to make sure they're in the earlier risk categories and not progressing. This is what we need to do. This is where we are with the burning platform. We need to just jump in and get this done. In the course of this presentation, which was an hour or just under an hour long, we've actually lost 600 people globally from diabetes and its complications. That is because the death rate is 1 every 6 seconds. And that has increased. In 2011, it was 1 every 7 seconds. It now increased in 2015 to 1 every 6 seconds. And that is despite conferences and technological advances and more people doing this. And it's because we don't really have a true understanding. The call from the IDF was at the 2015 World Congress in Vancouver, was get the healthcare practitioners out of the ivory towers, get them on the ground, truly understanding this with a focus on treating the patients earlier in the window of presentation and preventing them from progressing from risk category 1 to 2 and then onwards. But we want to keep them active, walking, and mobile so they can manage their blood sugars so their sugars doesn't elevate and kill off the blood vessels, cause neuropathy, which will inhibit them from walking. And we certainly want to see them well earlier than risk category 3, where it's already pretty late. So again, I urge you all to download the diabetic foot guidelines and the pocket chart on the IDF website. And I hope that everybody does this, and I hope this presentation is of help to you and of interest. And I look forward to seeing you all next year. And I'll be available for any questions, or contact me if you have anything that you would like to chat about. Thank you so much.
That's great, Dr. Langton. Thank you so much for attending and sharing such wonderful information. The work that the IDF has done is tremendous. I wrote an article on it based on your talk when we met in San Diego.
Oh, really?
And, those pocket charts are amazing. They pack so much information into such a condensed, simple, easy to read chart. And I recommend everyone to go and download that. Share it with your patients, because it's readable at the level of the patient as well. Yeah. And then, of course, the intrinsic minus foot is a tremendous model by which we can understand what's going on. And the effect of the fungus, the onychomycosis, as well. To understand that really opens up a whole new avenue of prevention for these patients. To ask just a question, it might be a little unfair, but what would you say to practitioners, particularly podorthists and orthotists who are seeing these patients every day? What one thing do you think we need to do better or pay more attention to in dealing with this population?
So that is differentiating the patients into those three categories. The patients are so confused when they come in. They just start talking and they're all muddled up. And even if they've seen their doctor or nurse practitioner, they can't differentiate it. Like, it's not well understood. And you actually have to stop them and say, well, stop. Let's talk about mechanical first, when you're weight bearing and walking. Secondly, we're going to talk about your back if you have problems. Thirdly, we're going to talk about neuropathy, which is numbing and tingling at night, and rest. And we talk about it in silos, and then they get it, because before they're so confused.
Right. Yeah. And of course, to them, a diagnosis of diabetes is just a diagnosis of diabetes. They don't understand the categories that they may be in.
No, but and neither does anybody else, because you're okay if you're risk category 0, you can wear whatever you want on your feet.
Right.
You just have to manage your blood sugars.
Right. Yeah. So helping educating the patient in that way, telling them you're in risk category, 0, 1, 2. That alone makes a big difference. Absolutely.
Yes, because they're thrilled if they're 0. they're very, very happy. And then we can just treat the mechanical problems. Right. And they're even happier because those are easy to treat, right?
Absolutely. Yeah. Very good. So thank you for sharing your expertise in the program.